Ohio House Bill 454, also known as the Save Adolescents from Experimentation or SAFE Act, Families, Aging, and Human Services Committee. Second hearing, May 19, 2022. Testimony by Dr. Andre VanMol, a family practice physician representing the American College of Pediatricians. Proponent.
I will now invite Dr. Andre VanMol, representing American College of Pediatricians, Christian Medical and Dental Associations. Just as a reminder to members, we do have 3 more witnesses after Dr. Andre VanMol, so keep that in mind as we're asking questions. And again, please, for both the members and witnesses, be sure to address through the chair. Thank you very much for being here. Welcome to committee.
Thank you. Chair Manchester, Vice Chair Catrona, Ranking Member Denson, and members of the House Families, Aging, and Human Services Committee. I have been introduced, so I'm not going to repeat that. I'm a board-certified family physician in full-time practice. That's what I do. HB 454, the SAFE Act, protects already at-risk gender dysphoric youth from experimental and unproven hormonal and surgical gender-affirming therapy, which medicalizes prematurely and permanently. Gender-affirming therapy, which I think is better termed transition-affirming therapy because that's what we're affirming, is not proven effective, not proven safe, does not reduce suicides, and is not the standard of care for gender dysphoria. The real science is driving an international pushback against GATT in favor of intensive psychological evaluation and support, and the lawsuits over the harms of GATT have begun. Those harmed by gender-affirming therapy would now benefit from a means of legal redress afforded by HB 454, something they lack in most other states. The medical literature is clear not to prematurely affirm. The APA Handbook on Sexuality and Psychology states premature labeling of gender identity should be avoided, and they state why. This approach runs the risk of neglecting individual problems the child might be experiencing. The 2020 Nordic Journal of Psychiatry had an article stating an adolescent's gender identity concerns must not become a reason for failure to address all of his other relevant medical problems in the usual way. Withers in 2020 stated trans identification and its associated medical treatment can constitute an attempt to evade experiences of psychological distress. We've heard several of those today. Desistance is the norm for minors with trans identification, resolving on its own for an average of 85% by adulthood unless it is affirmed. Affirmation short circuits natural desistance. Why would we permanently medicalize a child for a condition that usually goes away? Transition gender-affirming therapy is not the standard of care for gender dysphoria. Please hear me well here. It will save a lot of questions. Gender-affirming therapy guidelines ultimately derive from activist groups like WPATH, the World Professional Association for Transgender Health, which is not a scientific organization and whose standards of care appear to be both internally inconsistent and window dressing that is ultimately not followed. The 2017 Endocrine Society guidelines were significant because that was the first genuine medical organization approving of transition in certain well-selected minors, which they said was supported with low to very low strength of evidence. They state this on page 3895, the guidelines cannot guarantee any specific outcome, nor do they establish a standard of care. Gender-affirming therapy is not the standard of care. Minors cannot give truly informed consent. They have developing brains. They change their minds often. They don't grasp long-term consequences. They don't yet have the ability. A UK High Court in the Bell versus Tavistock decision in 2020 specified there is no age-appropriate way to explain to many of these children what losing their fertility or full sexual function may mean to them in later years. Many regret transition. Many claim that their consent actually lacked the full information on gender-affirming therapy's known risks and on the available alternatives. And I would warn the committee that studies that routinely downplay the rate of regret habitually have very high rates of loss to follow-up. The average is 20 to 60% loss, rendering the studies invalid. And they set unreasonably strict definitions for what even counts as regret. As you've heard several times, the governments and medical academic institutions of the United Kingdom, Sweden, and Finland have rejected prioritizing gender-affirming transition in favor of emphasis on mental health evaluation and support. Gender-affirming therapy's suicide reduction claim is a myth, though it's frequently used as emotional blackmail. Famed sex researchers, psychology professors Bailey and Blanchard said there is no persuasive evidence that gender transition reduces gender dysphoric children's likelihood of killing themselves. What you've heard several times today, that 2011 Swedish study of all post-sex reassignment surgery adults showed if you follow them 10 years out or more, a completed suicide rate 19 times that of the general population, 3 times the all-cause mortality, meaning all the things that can kill someone, and 3 times the psychiatric hospitalization rate. Now, many studies that claim GAT successes usually track patients for unacceptably short periods of time. You see 6-month, 1 year, 2-year studies, way too short. And they failed to capture these long-term problems. A 2020 study by Brandstrom and Pachankas, claiming to be the first total population study of almost 10 million Swedes, looking at their various registries that they keep in the country, ultimately showed neither gender-affirming hormone treatment nor gender-affirming surgery provided reductions of the mental health care benchmarks they looked at. The initial study said that was true of gender-affirming surgery, of gender-affirming hormone therapy, but said, oh, we think surgery shows some stuff. I led a team that wrote a published letter to the editors showing problems with that study. It was published with 6 other studies, along with an editor's correction saying they had the authors redo the statistics and show what they should have done in the first place, a before and after comparison of the mental health benchmarks relative to gender-affirming surgery. And when they did, none of the 9 things they looked at improved with surgery. Thus, I say, ultimately showed that neither gender-affirming hormones nor surgery were helpful. In conclusion, the chemical sterilization and surgical mutilation of otherwise healthy young bodies is not health care. This is unproven child experimentation masquerading as better. Minors should be protected from it, and those harmed by GAT would be benefited from the avenues of redress this bill provides. So I ask you please to support 454. And I thank you for your kind attention and for being so generous to grant people 5 minutes in testimony. I'm used to 2.
Thank you. Any questions for the witness? Representative Liston?
Surprising, I'm sure. Thank you for your testimony. I think one of the challenges of our group, of course, is weighing all of the information that we have and ensuring that we know the background of those who are providing that information. And so I see that you're here representing the American College of Pediatricians, and I know there's been confusion, so I want to make sure, this isn't AAP, American Association, or American Academy of Pediatrics, but American College of Pediatricians. And I want to read and make sure that this is the group. So this is just Wikipedia. The American College of Pediatricians is a socially conservative advocacy group of pediatricians and other healthcare professionals in the U.S. The group was founded in 2002. In 2005, it reported between 150 members and 1 employee. In 2016, it had 500 physician members. The group's primary focus is advocating against abortion and the adoption of children by gay or lesbian people. It also advocates conversion therapy. ACP Peds has been listed as a hate group by the Southern Poverty Law Center for pushing anti-LGBTQ junk science. A number of mainstream researchers, including the director of the U.S. National Institute of Health, have accused ACP Peds of misusing or mischaracterizing their work to advance ACP Peds' political agenda. And so I would ask, this is the organization you are representing, and you are actually not a pediatrician.
Chair Manchester doesn't look like it's Chair Manchester anymore, sorry. So Chair Catrona, what would be? To Representative Liston. I think those accusations are true of the people making the accusations. This is ridiculous slander. The Southern Poverty Law Center, SPLC, also called by some of my colleagues who have been slandered by them, slandering people like crazy. $400 million, $160 million of which is in offshore accounts when you shouldn't have a nickel if you're that kind of institution. They haven't done anything for Southern poverty in quite some time, and they're not a medical group. They are, in fact, themselves an advocacy group. Certainly not scientific. The way you've described ACPs is inaccurate. It's something that comes, again, from people that are themselves being hateful and unfair. There wasn't much in the timeline that was accurate either. And I don't understand where we're using Wikipedia as a source of information in the committee. That's a fine place to start.
That's why I'm asking you. This is the info I have on your organization.
Yeah, and I view this as jamming tactics, which Southern Poverty Law Center excels at, trying to intimidate testimony. This is part of the reason, a small reason. You don't get more doctors, more psychologists, more therapists here answering it. We have no witness protection program. We operate here under the constant threat of losing our jobs, ruining our careers, and potentially putting ourselves and our family in harm's way because we are here citing unpopular truth. So it's really easy to call unpopular truth anti-science or whatever it was you said, but I resent every bit of it, and I want that on record.
Thank you.
Any follow-up questions? Representative Edwards?
Thank you very much for your testimony today. I guess we should start calling this the Background and Research Committee. You know, you're a doctor, you're a pediatrician, but you're not from Ohio, and the Southern Poverty Law Center said something bad about you once, so you're not qualified, I guess,
Point of
to
order.
testify in front of this committee.
Not a pediatrician.
Chair,
Through the chair, the
Chairman.
question should be directed through the chair. Representative Edwards, your
Ms.
question.
Liston, do you want my time or? Okay, thank you. So anyway, I've been talking a lot about mental health in the committee today. And so are you aware of the studies that have been spoken about coming from Sweden? Are you aware of the other studies that are going to show different results? Is there a common denominator amongst those, amongst the issues with those studies that show a different result that have been discussed today?
Yes, Representative Manchester, Representative Edwards. As a board-certified family physician, I see people from cradle to grave. We do deal with children every single day. Just to clarify that.
Oh, sorry. Continue. Thank you.
Okay. There's decades of professional literature, decades from all over the world, particularly North America and Europe, showing the overwhelming propensity for there to be underlying mental health problems in people who identify as gender dysphoric. Really high probability. So we're talking mental health problems, adverse childhood experiences, traumas. Excuse me for hesitating for a second there. And of course, neurodevelopmental problems, autism spectrum rates very highly here. So the idea of what is the international standard of care, which is watchful waiting, which implies intensive psychological evaluation and support both of the child and of the family, because you are certain to find issues in both, in the best of homes. The idea is that's what needs addressing, and that by doing so, often the gender dysphoria resolves. But understand, when we say there's an 85% rate of desistance, that's with doing nothing. It will desist by adulthood. If you're actually allowed to bring in what's supposed to be there, therapy that helps look for other problems and helps the child deal with them, that looks at the family dynamics and helps address those and help those be dealt with, that the stats are really good. What adults do, that's an adult decision. Here we're talking about children. Advanced civilizations the world over protect children from decisions they're not old enough to make. We don't let kids in America drink till they're 21, and that's just alcohol, something far less life-changing and momentous than transition. Did I answer your question? Okay.
Follow up? No. Are there any additional questions for the witness? Representative Smith?
Thank you. Through the chair to the witness, thank you for coming today. I care a lot about mental health care, so I'm going to keep asking questions about that. And it sounds like you're another proponent of lots of counseling. Again, my understanding is that the standard of care is that exists today. But one problem with this bill is that it asks counselors and psychologists and healthcare professionals and school teachers to violate their professional code of ethics by violating the privacy standard that they have regarding those confidential conversations with their clients, which sometimes are children, adolescents, adults, whatever. So I'm concerned that this bill will undercut what you want and what everybody so far has said they wanted and what I want, which is counseling to be a part of this, mental health care. And so would you be in favor of removing this piece that requires healthcare professionals to violate that piece of the code of ethics where they have to report what was confidentially said? To make this bill better, would you be in favor of taking that out to ensure that counseling counseling happens.
Representative Manchester to Representative Smith, I think that misrepresents the bill and ignores what's going on. This counseling for underlying problems is not what goes on. It's famously not going on in gender clinics. It's impossible that a kid could walk in and out of a gender clinic or in and out of a Planned Parenthood clinic in 45 minutes with a prescription for hormones if it was going on. It's not. Again, the WPATH guidelines are often window dressing. Secondly, it's the parents' rights that are being violated here. And what actually ends up happening is one of the primary modes of this social contagion, the reason the stats are so much different now than they are in the DSM-5, is because schools are a main means of it. So it's all too easy for there to be this railroad where school counselors secretly affirm a child's confusion, secretly refer them to a gender clinic, and everything happens without the parents knowing, and yet the parents are responsible for everything that goes wrong.
May I have a
Follow-up?
Thank you so much. So, and you practice in California?
I do.
Okay.
I'm
and
sorry,
so-
Representative Manchester.
Thank you, sir. Follow up?
Thank you so much. I wanted to make sure that, I want to make sure that we're talking about sort of like what the standard of care is in Ohio, which you can't be familiar with because you haven't practiced here, but I get it. We're having a big conversation. Okay, but so let me get to my point. So my point is you're saying you would be in favor of keeping the piece of this bill that encourages or requires psychologists, healthcare professionals, counselors, teachers to violate their professional code of ethics by violating confidentiality. You are in favor of that
Representative
staying
Manchester, I'm sorry, did you finish? Representative Manchester, Representative Smith, I think you're misrepresenting everything. If a child presents complaining of being abused, that has to be reported. If a child reports that they were victimized by sexual violence, that has to be reported. That's part of the professional code of conduct too. There's all kinds of things in medicine and in psychology where there is mandatory reporting independent of what the child wants. So I don't agree with the way you phrase this as being a violation of professional conduct.
Madam Chair.
Follow up?
Thank you. I really want to read right from the bill analysis in LSC. It says this bill prohibits school nurses, this bill prohibits school nurses, counselors, teachers, principals, or other staff or officials from withholding or encouraging a minor to withhold from the minor's parent or legal guardian information that a minor's gender identity is inconsistent with the minor's biological sex, whatever that means. So this prohibits, what this says is it requires you to communicate any hint regarding, and that's the Ohio bill. So thank you for letting me clarify that.
Representative Manchester to Representative Smith, I think that's all appropriate things that a parent needs to know. If there's other qualifying problems in their fear of violence or whatnot, that crosses a line where the confidentiality is already protected. The problem is that we have a situation where any failure to affirm is referred to as though it were child abuse. And as far as coming from California, we are where Ohio is going. Please be warned by our experience, you don't want to go there.
Are there any additional questions for the witness? Representative Click?
Sharing your expertise. Is science any different in California than it is in Ohio?
Representative Manchester to Representative Click, science is science everywhere unless it's not being followed.
Thank you, sir.
Follow up?
Yes. So it is my understanding that it is 20 times, they're 20 more times more likely to succeed in suicide after transition, but we have reports from other places like the Trevor Project, and I don't think they're medical professionals, I think it's an activist group, that say that transition lessens the risk of suicide. How would you address that, sir?
Representative Manchester, Representative Click, when we're talking about the Trevor Project, I think we're speaking about studies with chief researcher being Green, one out of, give or take 2020, one more recent, which are very large, but entirely retrospective. That means you're asking people based on their memory. The way the people were recruited is questionable, lots of a bias, and as well as people who would have had positive experiences the other way are actually, and they say as much in the limitations section, excluded from the study. And the fact is, retrospective cross-sectional studies cannot be used to make statistical projections. It's a rule. It's part of epidemiology. you'll find that the vast majorities of these studies, claiming harm from absence of gender-affirming therapy or claiming success from it, are retrospective, cross-sectional, and are not up to the task of being used to claim good, bad, or indifferent.
Follow up?
Yes, thank you, Chair, through the chair. And so we know that it's 20, I call it 20/20 factor. I hear they're 20 times more likely to take their life, succeed in taking their life, which is different than suicidal ideation. And I understand, and you can correct me if I'm wrong, but it's my understanding that they also have an average of a 20 years shorter lifespan, perhaps because of the drugs that they're pumping into their body and other exterior factors. Is that, am I correct, or is that inaccurate, or do you have other comments on that?
Representative Manchester to Representative Click, in your second question, I see that I failed to answer the first one. You asked about the 20-year bit.
Yeah.
When life expectancy is shortened, again, you've got all these underlying problems. Now you engage in at least cross-sex hormones if you're doing it later on as an adult, and that means you're going to take part of all the complications that come with it, which are many. And in fact, there was an international report of international endocrinology groups that were asked in 2019 is when they published, what are the appropriate evidence-based uses of testosterone in women? And this was, the U.S. Endocrine Society went from all over the world. Going through the world literature, they came up with one short-term use for hypoactive sexual desire disorder, and only short-term because long-term safety has not been established. And that's talking about testosterone in way lower doses than are given for transition. That's one example of many of the complicating problems that can happen. So yes, your life expectancy is shortened, and suicide is not a small reason for that. On the Swedish study, understand one of their claims to fame is they followed 10 years out. Again, when you're following 6 months, 1 year, 2 year, you're not out of the honeymoon period. We've been told that repeatedly by detransitioners from coast to coast. They don't even know what they did to themselves in that amount of time. But you follow out long enough, and previously in the literature, the usual window for the big increase in regret is 8 to 11 years out. With the rapid onset gender dysphoria, with transgender ideation being spread now as a peer and social contagion, we're seeing the regret and desistance come much sooner. Did I answer your question that time, or did I get carried away with myself?
Yes, sir, you did. I have a follow-up.
Additional follow-up?
And so I believe it's accurate from what I'm hearing you say that in the short term, there's a euphoria perhaps where they could report, yes, I feel better, but in the long term, that wears off, and then there is major regret that leads to depression and perhaps suicidal ideations.
Representative Manchester to Representative Click, that is correct.
Thank you.
Representative Humphrey?
Thank you, Madam Chair. Hi, Doctor. Thank you for coming in today. I have a quick question for you. I want to know your perspective on, people who have gone through the transitioning process. With this bill, I guess essentially it would stop that process, and we know that if that happens, that would affect mental health and so on. So how, if this is passed, how do we think we're going to address that? Because this is going to be an issue. Thank you.
Representative Manchester to Representative Humphrey, to try to be specific here, and please catch me if I end up wandering, because you've actually asked about quite a bit here. The underlying mental health problems are not addressed by gender-affirming therapy. They're dodged. So they still lie there to be addressed, and they're the seeds of further regret. This bill pertains to children. Adults are free to make the decisions they choose for good or for bad. So I'm trying to limit my commentary here to kids and what's going on with them. And they need the underlying mental health evaluation and support that is all but banned. Because in all these states, many of these states with these so-called conversion therapy bans, therapists feel that they can't do anything that might dissuade someone who presents might be trans, because they're afraid for losing their license. It's part of the intimidation tactic that people are practicing under. So what we need is an expansion of available proper underlying mental health evaluation and support, evaluating problems in the child and family and trying to resolve those. That's not what's happening. And that It's kind of an expensive thing. You know, mental health stuff, a lot of insurances don't cover that well. It's coming out of people's pockets. You can't get that kind of therapy from a gender clinic. They have another initiative they're following. So it's those kind of services that really need to be advanced and expanded, and regrettably, they're just not there right now like they should be, which is to say the status quo is not safe.
Follow up? Representative Liston?
Thank you, Chairman. Just a couple of questions brought up by some of the conversations. I mean, obviously science doesn't change, but the practice of medicine and the application of science is certainly variable. A couple of contexts where this, I think, is important. One, you know, people keep talking about this Swedish study that was published in 2011, but included individuals that received treatment in 1973, right?
30 years. I'm sorry. I shouldn't have done that.
I'm sorry?
I interrupted you to Representative Manchester to Representative Liston. I'm sorry I interrupted. I just meant to clarify. It was a 30-year follow study.
Right, starting with patients in 1973 and accruing up, you know, a couple hundred individuals over time. Would you say that the treatment of these individuals was the same in 1973 as it is now in 2022? We're talking 50 years later, and making judgments on current practice of medicine based on 50 years ago.
Representative Manchester to Representative Liston, I also mentioned Brandstrom and Pachenkus, which is as modern as they come, and was huge. You know, 10 million electronic medical records in Sweden looked at. And again, I was part of a letter writing campaign that got that study properly evaluated to show what it did, that neither gender affirming surgery.
I'm sorry, I'm just asking about the
Through the
study
chair to the witness.
Through the chair, to the witness, I'm asking about the study that everyone keeps talking about in 2011, in terms of the treatment was 50 years ago. One would assume, however, that the treatment was different 50 years ago.
Representative Manchester, Representative Liston. Surgeries are better. The form of hormones used are better, but things aren't that different. Also, that study was particularly well done, and the modern studies are particularly poorly done. It's some of the lowest grade evidence, lowest quality studies that we're seeing in all of medicine is happening in this gender treatment field.
Follow up
through the chair. So, I mean, I guess we're talking about saying things might be the same as 50 years ago, and your experience currently in terms of what's actually happening is, again, across the country. What information do you have about Ohio's practices regarding the gender affirming care and the treatments offered and the emotional support and mental health services that these clinics provide? Sorry about that.
Representative Manchester, Representative Liston, what they're requiring, they're not getting. And whatever I knew before, I got more confirmation today. The sales pitch is different than what patients are receiving. It's this way everywhere in America with gender clinics. So I've heard several times today, Representative Manchester, several members say, oh, everybody's getting a full evaluation every time. That's unsupportable based on the testimony we've been given today alone. It's not that way. I know it sounds offensive. I know it sounds shocking. This isn't the first time the medical community has gone really wrong on something. It happens about every 20 years. We could have been making the same statements about the lobotomy craze of the 50s and 60s. The neurologist from Portugal who invented lobotomies got the Nobel Prize in the late 40s. In the 50s and 60s, that was the way you handled mental health problems. Look what happened to poor Rose Kennedy, and people were mocked and denigrated and called less than professional and less than up with the times for not being a part of it. But now we look at it with dread. We can't believe we did that. Likewise, a century ago, leading up all the way to the 70s and 80s, it was still done. The euthanasia movement and the forced sterilizations that happened. My state of California in 2021, North Carolina in 2012, and somewhere in between Virginia, have instituted programs to offer financial compensation to people that are still alive who were sterilized under the eugenics program. The states are going to get to do that again with gender-affirming therapy.
Madam Chair, I'd like to circle.
just to the members, please allow the witnesses to finish answering their questions in full before interrupting with an additional question. Thank you. Follow up?
So what I'm hearing is that there's no specific information you have on Ohio, but rather the understanding that this is everywhere and hasn't changed much in the last 50 years.
Representative Manchester to Representative Liston, we're now answering what sounds like 2 or 3 different questions. What's happening in Ohio now has been spoken of here, and it's not a secret. Your focus on that 50-year-old study, or excuse me, that study that would go back to include periods 50 years ago, is fine. It's not the only study I quoted. It's not the only study I gave in my written testimony. There are lots of others. The modern ones aren't very good, like Trevor Project and Green, that are thrown by activists to legislators and other places very quickly to make sure you're quite informed of these very poorly executed studies that don't show what they claim to. But what's happening in Ohio, we've heard from from people here giving the testimony, wiping the tears from their eyes. I think what's happening here is evident.
Are there any additional questions for the witness? Representative Click?
Thank you, Chair, and Dr. VanMol. You referenced the WPATH standards of care and quote-unquote standards of care. And I was just looking at that. I have that up on my screen right now, and it actually says that gender dysphoria during childhood does not inevitably continue into adulthood. Rather, in follow-up studies of prepubertal children, mainly boys, who were referred to clinics for the assessment of gender dysphoria, the dysphoria persisted into adulthood for only 6 to 23% of children, and boys in these studies were more likely to identify as gay in adulthood than as transgender, and so forth. So even though they perhaps get it wrong in some places, would you agree with that statement that the actual rate of persistence is very low?
Representative Manchester to Representative Click. Yes, desistance is very high, persistence is very low. You can increase persistence by affirming, and that's why it's a bad thing. They don't need affirmation at this stage. They need the psychological assistance, support, evaluation. They don't need to be pressured into a transition that's being put forward as a cure-all solution when it's not up to the task. And you mentioned the gay and lesbian aspect. You realize this is a hands-across-the-aisle effort. I'm here representing the organizations I do, but the people opposing gender-affirming therapy for minors, it's the religious, it's the a-religious, it's the GLBT, it's the not. It's all comers of the political parties coming together because it is a bad idea to be transitioning minors. Adults get to make their adult decisions. We need to protect children from making decisions they're not up to.
Are there any additional questions for the witness? Seeing none, thank you very much for your time today. We appreciate it.